Module 9, Patient Case Scenarios. Presented by Amy Wermeyer, PharmD, board-certified psychiatric pharmacist with the School of Pharmacy at North Dakota State University. Hi, Anna. Okay, great. Looks like you have a new prescription for a pain medication. Okay. We've started a new process in our pharmacy with every pain medication where we have you fill out this form. It's pretty short, shouldn't take you more than 2 or 3 minutes, and I'll get started on processing your prescription. Okay, thanks. This is the prescription that Anna presented with today. Note that it is for hydrocodone and acetaminophen 5/325 every 6 hours with a quantity of 56. This is the patient intake form that Anna filled out. Note that she has not taken this opioid or other opioid medications in the last 60 days, and she has indicated that she has a family history of alcohol abuse and prescription medication misuse. On the patient intake form, the bottom section, Anna has also indicated that she is greater than 64 years of age, she has anxiety, she takes a medication to treat anxiety, including one of these, and she has answered no to all of the remaining questions. Now keep in mind that the bottom section of the patient intake form will help us to assess risk for accidental overdose, whereas the top section in the table form will help us to assess risk for opioid misuse and red flags for that condition. Also note that Anna has circled no for alcohol use, but then she's written in a comment that she uses 1 glass of wine per night. So really, her answer probably should be yes to this question, and that's something that we should keep in mind as we assess her risk for accidental overdose from opioids. So now I'm going to take Anna's patient intake form and put it next to the ORT score sheet, which is available on the OneRx website in the workflow documents section. And I'm going to go ahead and score the responses that Anna indicated on the patient intake form. So she's female, and she said yes to a family history of alcohol, which earns 1 point. And she said yes to a family history of prescription medications, which warrants an additional score of 4 points. So that gives Anna's total score on the opioid risk tool as a 5. Now that I know that Anna's total risk score on the opioid risk tool was 5, I can pull out the triage tool that's also available in the OneRx workflow documents, and I can decide what interventions I need to utilize when working with Anna in her encounter with me today. So since her ORT score was less than 8, I will proceed to the right on this triage tool and start to look for red flags. I'll look at her prescription drug monitoring program report, and I'll consider my professional judgment as far as risks of or indicators of opioid misuse. I've pulled Anna's prescription drug monitoring program report for the last 12 months. You can see that she has had 2 alprazolam fills in the last 12 months, both of them for a quantity of 30, which was a day supply of 15. And there is no overlap in the dates with which these were filled, indicating that she most likely hasn't been using more alprazolam than was prescribed to her. Also, she's never filled an opioid before, at least not according to the prescription drug monitoring program record. And there are no concerns for multiple requests for early refills, no large quantities prescribed, she's not obtaining prescriptions from multiple providers, and she's not using multiple pharmacies. So that's very reassuring. When I go back to the triage tool, I can cross out red flags and know that I've checked the prescription drug monitoring report, and there's no indication that I need to contact the prescriber because of concerns about misuse. So that leads me further to the right to begin assessing for accidental overdose. Looking at the bottom half of the patient intake form that Anna completed allows me to perform an assessment for accidental overdose risk. So, two important factors that I'll want to take a look at are that Anna indicated yes, she does take a medication to treat anxiety, specifically a benzodiazepine. She takes alprazolam, as we saw from her prescription drug monitoring report. And that's something I'm going to converse with her more about when I talk with her, so I can get a better idea of how significant is the risk for accidental overdose, according to her alprazolam use coupled with her new opioid use. And also, I'll note the fact that she indicated she uses some alcohol, and use of alcohol in combination with an opioid confers greater risk for accidental overdose than does non-use of alcohol when an opioid is on board. So from this, we can conclude that she does have some risk factors for accidental overdose, and she's also greater than age 64, and so that would lead me to conclude that the risk is substantial. Another bit of information that we ought to consider when evaluating risk for accidental overdose with an opioid prescription is the morphine milligram equivalence. So I've used the CDC smartphone app to calculate the morphine milli equivalence for this prescription, and it turns out that it's 20. And as we learned previously, the risk for accidental overdose is quite significant and concerning when morphine milligram equivalents are greater than 50. So since hers is less than 50, we don't have to be extremely concerned about the amount of respiratory depression that this prescription could confer. But because of her other risk factors, we'll still consider her to be at risk for accidental overdose. So returning back to our triage tool, we can see that there are risk factors for accidental overdose, and that leads us to conclude that we need to deliver prescribing of naloxone and counseling about opioid pearls as our interventions in our encounter with Anna. Anna, would you mind following me into our consultation room for a couple of minutes? Okay, so we're working on your prescriptions. Is it okay if we talk about them a little bit?
Sure. Yes.
Okay, great. Tell me what you already know about this new prescription for hydrocodone and acetaminophen.
Well, not that much. I know it's for the pain in my knee. I fell down a couple of weeks ago, and I really banged up my knee. It hasn't gotten any better, so I finally went to see my doctor. Is this one of those opioids I hear so much about?
Yes, it is. Yes. So I'm hearing that you know this medication is for your pain, and that you've heard of opioids before. Mm-hmm. Did your doctor mention anything to you about how long you'll take this medication or what the goals for your treatment are?
Let's see. I think not for very long. I suppose it's because this medication can be dangerous.
Right. Yes, the danger of opioids is certainly something for us all to keep an eye on. But it's also important to remember that these medications are very helpful for short-term use for treating severe pain. So that's kind of what we want to focus on with this medication. It will be really important for you to kind of keep an eye on your pain in relation to when you take a dose of this medication. And also to think about how you're functioning during that time as well. So for instance, if you take a pill and you notice about a half an hour later that your pain drops from like an 8 to a 3, then that's good. But if you find that you're not able to still get up and function and move around and accomplish what you want to, then that's also very important information for the doctor to know and can help them decide how they're going to treat your pain going forward. Okay? Let's see. So the doctor has ordered enough medication to last for 2 weeks. But I would really encourage you to evaluate how your pain and your function are responding sooner than that, maybe like in 5 or 6 days. And in fact, I could even just fill half of this prescription for you if you wanted, and that way you could decide if you think you need more at that point, and you could come back and get the rest. But if you don't need it at that point, then you don't have extra pills lying around that you wouldn't end up needing. What do you think?
That makes sense.
Okay.
I've got an appointment with my doctor in 6 days. That ought to work.
Yeah, that sounds perfect. Okay. I have a couple of additional items to discuss with you, if that's okay. Do you have time now?
Oh, I've got to pick up my granddaughter from her dance class in 15 minutes. I could probably spare 5 minutes.
Okay, I'll try to be quick.
Okay.
Okay. So first of all, if you have some of these pills left over, let's say a couple of weeks from now, it's best not to keep them lying around your home. It's been known to happen that folks have someone come into their home and go looking for pills and take them from you. And so we're trying to do our best to make sure that there are as few pills laying around in the community as possible. So a couple weeks from now, if you still have some left, you can bring them back here and we'll dispose of them for you in our medication take-back bin.
I hadn't thought about that. What a good idea.
Yeah, a lot of people don't realize and don't think about that often, so that's good. Okay? What have you heard about the potential for opioids to be addictive?
Oh, it's in the news all over. You hear about people popping pills, getting hooked. Some people even died from taking too much. That's really scary stuff.
Yes.
You know, I'm not that kind of person, though, so I'm not really worried.
Okay. You bring up a really important point, which I'm glad you brought up, and that is that it turns out that just about anybody could get addicted to an opioid. It could happen to anybody who starts taking one, not just, someone who might look like they have that potential. So the form that you filled out tells me that you have a couple of risk factors that put you at a little bit higher risk of developing an addiction than maybe someone in the average population. And that has to do with some of your family history. So would you mind if I tell you a little bit more about this type of condition and your risk for it?
No,
Okay.
Please do.
Okay. So opioids have powerful effects on the pleasure centers in our brain. They have the ability to make us feel more pleasure than any natural thing in our environment would. And that's not such a bad thing in and of itself, except that our brains can start to develop some cravings for that pleasure sensation and actually cause people to start using medications strictly to try to get that pleasure rather than to treat their pain or continue to use them even when their pain is gone. Okay? Oopsies. So, that some people seem to be more susceptible to this pleasure feeling, and that includes people who have a family history of prescription drug abuse or alcohol abuse, like I saw you indicated in your family history.
Yeah.
Okay, so you're at a little bit higher risk, and it doesn't mean that you shouldn't take these medications. It just means that you and I and your doctor should keep a closer eye on if you find yourself starting to develop some cravings or find yourself wanting to use the medication even when it's not yet time to take the next dose, or you find yourself looking for that pleasure sensation rather than just to treat your pain. Okay? Okay. It's not very likely to happen, and it's definitely a medication you should still take to treat your pain, but I just wanted to make sure you were aware of it. Okay? Let's see. Now, that was a lot of information I just told you. Can you tell me what you take away from that?
Well, it sounds as if I should be careful not to get hooked on some of that. I don't want to get an addiction to opioids. It's that good feeling that could get to me. Did I get that right?
Yeah, you sure did. That's right. So if it's okay with you, I'm going to move on from that topic now and talk about something else related to the medication.
Okay.
Okay. What have you been told about other side effects of this medication?
I think my nurse said that it could cause constipation and something about breathing.
Yeah, you're right. Yeah, this can definitely cause some constipation. I would really encourage you to eat plenty of fresh fruits and vegetables and take in plenty of non-caffeinated beverages to help kind of ward that off. But if you should develop constipation, then just give me a call and I can recommend some over-the-counter medications to help combat that. Okay? This can also cause some dizziness, drowsiness, and maybe problems with balance or making your balance feel a little off. Okay? So it's really important that you not drive or do other things that require a lot of attention or dexterity until you realize how this is going to affect you. Okay? As far as the breathing side effect of this medication, that's something we call respiratory depression. And that means that the medication can slow down your brain's drive to breathe and also make it more difficult to recognize when you're not breathing fast enough to oxygenate your body. And the danger there is that it could actually lead to death from lack of oxygen. Now, this is a very rare effect, but it's something that we really want to try to focus in on and make people aware of so that they can prevent, more real serious problems from coming up. You actually are at a little bit higher risk of having your breathing be severely slowed down because you also take the medication alprazolam. Can you tell me how often you've been using your alprazolam?
Well, before this knee thing, I was taking it maybe every couple weeks. But with this knee problem, I've been feeling more anxious and having panic attacks. So I suppose maybe once every couple days.
Okay. Okay. I'm sorry to hear you've been struggling with anxiety. I'm sure that must be very frustrating. Yeah. Hopefully we can get you on the road to recovery, both with your pain and with your anxiety, by using this medication for a little while to help. Yeah. Okay, so because of that higher risk of slowed breathing, I'm actually going to prescribe another medication for you that's called naloxone. Have you heard of naloxone? It's also called Narcan. This medication can reverse the effect of an opioid if you were to develop a problem with that really slowed breathing. So if someone came upon you and found that you were looking like you were passed out or in a coma, or breathing really, really shallowly, or seeming like you were choking, turning blue, those would all be reasons to suspect that your breathing had been slowed down by this medicine. And obviously you wouldn't be able to give this medicine to yourself at that point, but someone else could give it to you. And they would do that by administering it in your nose. This is a nasal spray medication. So they would insert this part into your nostril, push on this button, and that would deliver a dose up into your nose. Okay? And if you didn't come around within 2 or 3 minutes, they would need to give you another dose of it. So I've put 2 of these in the bag for you to have around, to have at home. Okay? It's important for other people to know that if they needed to give you this medication, that they also might need to administer CPR to you to help you oxygenate your body until more emergency help could be given. And it's also important that someone would immediately call 911, because we would need to make sure that you get emergency treatment to make sure you survive beyond the effects of the medicine. Okay? Okay, let's see. It will be important that you and I educate others around you in case an emergency situation like that were to happen. So I would ask you to share this information with others around you. Okay? Let's see. I need to verify that, as far as you know, you don't have any allergies to naloxone.
No, I don't think I have allergies.
Okay.
Would it be okay if I ask my daughter to call you after I get home? She knows quite a bit about my medication, and I'd like to have her have this information.
Yes, of course. That would be great. She is welcome to give me a call, and I can talk with her through things on the phone, or she can stop by and we can visit about all this information. Good. Okay? I'm also going to be sending you with some written information, some brochures and pamphlets and things, so she can look at those as well.
Good.
Okay. Let's see. There's just a couple more things I need to talk with you about. Let's see. If you were to be given a dose of this medication and you kind of came to, you might be restless or kind of agitated or confused. That wouldn't last very long, not more than an hour or 2 generally, and it's not life-threatening, but it can be a little bit uncomfortable. So I just want you to be aware of that. I also want you to make sure that this gets stored in a place that's dry and about room temperature, just to make sure it stays as fully active as it can.
Sure.
And there's an expiration date on the back here. So when this expires, you'll need to dispose of this one and come back here to get a new one if you're still taking an opioid type medication.
Oh, yeah.
Okay? Okay, now, like I said, I will be putting some of those brochures in this bag. They're here. So this one talks about opioid use in general and some of the pros and cons of opioids and their use in our community. And then this one talks about what someone would need to do if they came upon you when you were not breathing very well or turning blue or what have you. And then the specifics about giving the medication to you, some specific instructions. Okay? Now, I've given you a whole lot of information in a short period of time. Can you give me a quick rundown of what you take away from this before you head out to pick up your granddaughter?
Oh, dear. Okay. I should not take naloxone unless I stop breathing.
Yep.
I should take the pills for the next 5 days, then see how I'm feeling.
Mm-hmm.
I should watch out for constipation. I should watch out for signs of addiction. I shouldn't drive. Oh, I better pick up my granddaughter before I do that.
I agree. That sounds like a good plan. Okay, do you have any questions?
Plenty. But
Plenty?
I'll talk to you about that later.
Sounds good. And your daughter can ask me too.
Okay.
Okay. Thank you so much, Anna. It's good to see you.
Yeah.
Take
Good
care.
to see you too.
I provided Anna with several pieces of paper to take home with her to read more about opioids and naloxone. This is the 1 in 4 brochure that talks about the risks associated with opioid use. And you can find this on the OneRx website. I also went through the naloxone dispensing and consultation checklist with her. This is also available on the OneRx website. And I provided her with the OneRx naloxone brochure. This gives guidance about what to do in the event of finding someone who appears to have had an overdose and the specifics of naloxone administration for the rescuer. Now that I have completed my encounter with Anna, I'm going to take out the outcomes worksheet that can be found on the OneRx workflow documents section of the webpage. And I'm going to complete this sheet based on my encounter with Anna, and then I'm going to enter it into REDCap. Alternatively, I could enter this information directly into REDCap if I were not using a paper-based process in my pharmacy. So I will indicate that yes, Anna was identified as at risk for accidental overdose, but I will indicate no, that there were not 1 or more red flags identified, and there were not potential opioid use issues based on the PDMP results. I did discuss medication take-back program with Anna, and I did partially fill her opioid prescription, and I did explain opioid use disorder to her. According to the triage tool, I would not have needed to do that because her ORT score was not greater than 8. However, since she did have a family history of substance use issues, I chose to go ahead and discuss it with her, as well as the fact that she sort of brought up the idea about addiction and the dangers of opioids. So I felt that it was pertinent to our conversation, but it wouldn't have been something that would have been absolutely required according to the OneRx program. Also, I'll indicate on the outcomes worksheet that community support or treatment services were not indicated for Anna. I did explain the benefits of naloxone, and I prescribed naloxone to her. I dispensed the nasal spray formulation, and her copay was between $0 and $10, very inexpensive for her, according to her insurance. And I did not contact the prescriber of this opioid medication, and I spent about 10 minutes total in my encounter with Anna. Hi.
Hello.
Okay. Looks like you have a prescription for a pain medication. We've started a new process at our pharmacy that involves filling out this form for anybody who comes in with a pain prescription.
Okay.
So if you wouldn't mind filling out this form, I'll get your prescription started, and it shouldn't take you more than 2 or 3 minutes to fill that out,
Okay.
and then I'll call you and we'll chat a little more.
Sounds good.
Okay,
Thank you.
thanks. Here is the prescription that Sam presented to me today. It is for oxycodone 3 milligrams 3 times daily with a quantity of 15. Here is the patient intake form that Sam just completed. He indicated that yes, he has taken an opioid medication in the last 60 days. Yes, he has a family history of alcohol use disorder. Yes, he has a history of prescription medication misuse in his family. And yes, he has a personal history of alcohol use. He also indicated yes, his age is between the age of 16 and 45. And that he has a diagnosis of depression. In the bottom half of the patient intake form, Sam indicated he's less than 45 years old. He has a history of depression. He does not use a benzodiazepine to treat anxiety, but he does use a medication to treat depression, and he does use alcohol. So those will all be important for me to consider as I start to work through the triage tool document. Now I'm going to score Sam's patient intake form using the ORT score sheet that is available on the OneRx website in the workflow documents section. I'll designate 3 points for Sam being a male with a family history of alcohol use disorder, and 4 points for him being a male with a family history of prescription medication misuse, 3 points for his personal history of alcohol use, and 1 point for his age being between 16 and 45 years of age, and an additional 1 point for his diagnosis of depression, resulting in a total score on the ORT of 12. So when I pull out the triage tool that's also available on the OneRx workflow documents site, I will see that I need to start going in an upward direction when I evaluate what intervention I need to use with Sam, because his ORT score being 12 is greater than 8. So now I'll need to proceed to evaluating whether there are red flags and take a look at his prescription drug monitoring program report to decide what I need to do next. This is Sam's prescription drug monitoring program report for the last 12 months. We can see that he has several recent fills for opioids. According to the dates, the quantity, and the day's supplies, his last fill of oxycodone was prescribed to last until October 1st, but today is September 29th, and he brought a prescription for additional oxycodone. In addition, an earlier fill this month, he filled a 7-day supply of acetaminophen with codeine, but followed that with an oxycodone fill 2 days later. These represent early fill requests. He hasn't received any of his opioid prescriptions from the same doctor, and all of these represent red flags for potential misuse and make me concerned about Sam. We can also see he has used several different pharmacies as well, and that's another potential risk factor indicating that there may be opioid misuse going on. Returning to the triage tool and proceeding upwards after I circled greater than 8 as his score, I have found that there are red flags and his prescription drug monitoring report is concerning. And so I am going to go ahead and contact the prescriber to discuss this opioid prescription and to make sure the provider is aware of the other opioid fills that have recently occurred. Looking at the bottom half of Sam's patient intake form, I'm going to be evaluating his risk for accidental overdose. And there are 3 important factors for me to consider. He has a diagnosis of depression, which increases his risk for accidental overdose. He takes medication for that. And he uses alcohol, which also increases his risk for the development of an accidental overdose. I calculated the morphine milligram equivalents of Sam's oxycodone prescription, and you can see that the total morphine milligram equivalence was 135. And if you recall, the CDC has said that opioid prescriptions with a morphine milligram equivalent greater than 50 to 100 confer a much greater risk for accidental opioid overdose than do prescriptions that have a morphine milligram equivalent less than that 50 milligram threshold. So this is also quite concerning as far as a risk factor for an accidental overdose. So putting this all together leads me to conclude that I need to deliver the prescription of naloxone as an intervention for Sam. I also need to counsel him on the potential for substance use disorder and community support services that are available. And I need to counsel him on opioid prescription pearls. Sam, would you mind having a chair?
Sure.
Thank you for filling out our form. I really appreciate it. I have some concerns about the medications today that I wanted to talk with you about. Our records indicate that you're filling this opioid prescription sooner than your last prescription for them would call for. Can you tell me a little bit more about why that might be the case?
I need that medication. I just have so much pain in my knee. You have to give me those pills.
Okay. I'm hearing that you're struggling a lot with pain. That must be very difficult. Can you tell me a little bit more about the pain and its timing in relation to when you take a dose of oxycodone?
I don't know. I hurt all the time. I feel, after I take one, it's better for an hour or so after I take a pill. But then it's back again just as bad as it was before, so I take another one. I take like 7 or 8 in a day, and I'm still doubled over half the time.
Okay, so you're telling me that the oxycodone seems to help for a short while after you take it, and then not very long after that you're having pain return. Is that accurate?
I guess so.
Okay. Okay, thanks for telling me about that. I know this can be challenging to talk about. I'm concerned that this medication may actually be causing you more harm than it is good. What do you think?
I don't know about that. It's like the only thing I've got to rely on.
Okay, tell me more.
Well, I'm just so down all the time because it hurts so much. Those pills give me at least a few hours of the day when I can enjoy life a little. When I try not to take them, I end up crying, having shakes or chills, or just lying in bed because nothing feels like it's worth doing without one of those pills in my system.
Okay.
Lately, I have been lying in bed anyways, I guess. I just want to get up, feel good, and go to work and stuff like that, you know?
Okay. So these pills are meant to treat acute severe pain that lasts only for a short while, and they're meant to be taken only for a short while, a few weeks at the most. And when they're taken long term, they can actually make people's pain worse over time. And so I'm concerned that might actually be what's happening with you. And they also have a tendency to trick your brain into thinking that you need the medication because they can make emotions feel better rather than just making actual physical pain feel better. Have you ever found yourself taking one to try to make your emotions feel better rather than your physical pain?
I mean, yeah, I guess.
Okay. It sounds to me like these pills aren't actually getting you to a point where you really want to be as far as the goal for how you want to function in your day-to-day life. Do you think that's the case?
Oh, I don't really want to agree with you because you'll probably tell me you're not going to give me my pills, and then I'll really be in a mess. But yeah, I'm not doing very well on these pills. Maybe I've lost control
Okay.
of things a little bit with them.
Okay. Thank you for being honest with me about that. This is, like I said before, a challenging topic to discuss, and I really appreciate you talking with me about it. But keeping on the path that you've been on with these opioids is really quite dangerous and could even lead to death. So I'm really concerned, and I'm glad we're talking about it today. These opioids, when taken in excess, can be very dangerous and possibly even deadly.
Yeah, my buddy's cousin just died from a heroin overdose not too long ago. Like 2 months ago, he hadn't even been taking the stuff. He'd just been taking pills like I am.
Wow. Yeah. It's amazing how fast opioid addiction can overtake someone's life. I bet you didn't head into your knee reconstruction surgery with the plan of ending up this way, huh?
Nope, sure didn't. So what do I do now? Where does this leave me?
Okay, here's what we're going to do. So I'm going to fill your opioid prescription today for oxycodone because I don't want you to go into withdrawals before we can get you connected with someone who can help you work through that, okay? But I'm not going to fill that prescription until I give your doctor a call and let him know about our conversation because I want him to know what we talked about. And I'm also going to ask him not to write any more opioid prescriptions for you because I want to try to help you stay safe, okay? Also, I'm going to fill a prescription for you called naloxone. It's a medication that can reverse the effect of an opioid if you were to have too much in your system. And I'll tell you more about that in a minute. Okay? And third, I'm going to give you some contact information for some community support services around us that you can call to get some help, some treatment centers that you can get connected with. What do you think about that?
No way. I'm not calling anybody. I'm not a druggie.
Okay. I'm not trying to say that I think you're a druggie. I'm not even qualified to evaluate that. I just know that trying to do this on your own can be very challenging. And you're telling me that you've tapered off of an opioid before, but yet you're here trying to get more oxycodone just 2 days after you previously filled some. Can you tell me about how you think this time would be different?
I don't know. Maybe it wouldn't be different. Okay, you can give me their numbers and I'll call, but I won't guarantee I'll walk through their doors.
Okay, I'll take that. I'll accept that as an excellent first step. A phone call is better than nothing. Now, about the naloxone that I mentioned, it's also called Narcan, and it's a medication that can reverse the effect of an opioid if you were to get too much in your system and be turning blue or choking, having difficulty breathing or not breathing at all, appearing like you're passed out or in a coma. Someone around you could administer this medication to you and it would reverse the effect of the opioid and possibly save your life. You know, you could die by stopping breathing, but this would help you to restore your breathing. Okay? So whoever would administer this medication to you, this is a nasal spray, and they would just put this tube part into your nostril, push on the actuator device down below, and that would give you a dose of the medication. Okay? If you were to not revive within 2 to 3 minutes after getting the first dose, then they would need to give you another one. So there are 2 of these in this bag. Okay? If a person found you like that, unresponsive, turning blue, choking, etc., they may need to also do CPR to help you survive, and they definitely would need to call 911 because emergency personnel would be needed to help ensure you survive, even after the medication is given. Okay? Also, let's see, it will be important that you and I educate others around you that you have this naloxone and that they could give it to you if they found you in that situation.
Okay.
And let's see, it'll be important that you store this in a dry place and at a room temperature location so that it stays active and viable. And there's an expiration date on the back here, so you can just kind of keep an eye on that. And when this expires, you'll need to come back and get another one to keep around your house. And we recommend that anybody who's had any kinds of problems with using opioids more than what was prescribed for them, taking them more often or in larger quantities, that they keep one of these around just in case they would relapse back into that prior behavior. And this is there as kind of a safeguard. It's kind of like having a fire extinguisher in your house. You hope you never have to use it, but it's there just in case you do.
Sure.
Okay. So I would prescribe this one for you and something that you would take home. Is that okay with you?
Yeah, I should probably have that.
Okay, sounds good.
By the way, are you more likely to die of a opioid overdose if you stopped using and start using again?
Yeah, that's true. Have you heard of the concept called tolerance, where you may need more of a medication to get the same effect?
Mm-hmm.
Yeah, opioids definitely bring about that effect in our brains, and they make it so we need more of the medication to get the same effect. But if you stop using one of them for a while, then your level of tolerance goes back down, and that would make you more susceptible to the effects of the opioid, especially the stopping breathing type effect, if you were to start using an opioid again.
Okay.
Yeah, so that's definitely the case. But naloxone could prevent death in that situation if you have it around and someone is able to administer it to you.
Okay.
Okay? Let's see. If you got a dose of naloxone, you might, when you wake up, you might be restless or agitated or feel very sick to your stomach, maybe even kind of angry and irritable. But that shouldn't last more than 2 hours. And those symptoms, though uncomfortable, are not life-threatening and not something that would be worth avoiding by taking the risk of you dying or something like that. Okay? Let's see. So this paper has a lot of that information that I was telling you about the naloxone, some of the recommendations about what a rescuer would need to do if they came across you in that situation, and the instructions for how to administer that naloxone medication. So
Okay.
please show that to your family members when you show them the naloxone.
Okay.
And then this is another brochure about opioids themselves that I'll send with you as well.
Okay.
Okay? Any questions?
Nope.
Okay. I'll be right back if you wouldn't mind just holding tight for 1 second.
Sure.
Sam, I heard back from the doctor that prescribed the oxycodone prescription for you, and he said that he was really concerned about you, and he hopes that you'll get well and get healthy. He said that he doesn't plan to write any more prescriptions for opioids for you, and he thinks that it will probably be difficult for you to get opioids from several other doctors around the area. But he really, like I said, wants you to get healthy. So he went ahead and made an appointment with both your primary care doctor and your surgeon in the next 2 weeks so you can get connected with them, talk about other ways to manage your pain besides using the oxycodone. Okay? And here is the information that I was talking about as far as the community support services, the phone numbers that you can call.
Okay.
Okay? And then I also wrote the dates of your appointments and on that sheet as well.
Okay.
Okay?
Thank you.
Thank you.
Wow, this trip to the pharmacy didn't turn out how I thought it would. I thought you guys just handed out pills. But I think you really helped me a lot today.
Good. I'm glad. You take care.
Thank you. Appreciate it.
Okay. I provided Sam with the 1 in 4 opioid brochure. I also provided him with information about community support services, so I utilized the links available on the OneRx website in the referring patients to treatment section. And I provided Sam with the identifying information for the 58103 zip code from the SAMHSA treatment locator map. So I gave him contact information for somewhere between 3 and 5 substance use disorder facilities that he could contact, and I highly encouraged him to do so. I also went through the naloxone dispensing and consultation checklist with Sam and indicated or made sure that he was aware of all the information. And I also provided him with the OneRx naloxone brochure that gives guidance to a rescuer about what to do and how to administer the naloxone. Now that I've finished my encounter with Sam, I'll complete the outcomes worksheet on paper and enter it into REDCap, or go ahead and complete it electronically right in REDCap. So I indicated that yes, today Sam was identified as at risk for accidental overdose, and that yes, he was identified with one or more red flags of opioid use disorder. And yes, that he was identified with potential opioid use issues based on the PDMP results. No, I did not introduce the medication take back program with Sam. It was not offered because I felt the prescription quantity was too small. I wanted Sam to be able to get in contact with community support services and work with them on stopping his opioid use or tapering off of it, rather than me only giving him part of the supply and limiting the time until he would go into withdrawal, perhaps resulting in that happening before he's able to get in contact with supports. Yes, opioid use disorder was explained and discussed with the patient. And yes, I did discuss community support services information with Sam and provided him with contact information. Yes, I discussed the benefits of naloxone. And yes, I prescribed naloxone to him. I prescribed the naloxone nasal spray formulation. And he also had a very low copay for the naloxone, which was fortunate. And yes, I did contact the prescriber of the opioid medication, but we decided not to change anything on the prescription. As I mentioned before, we decided to go ahead and allow him to have that amount of oxycodone in order to sort of buy him some time to get into contact with community support services and hopefully to enter into opioid use disorder treatment.